Dear Facebook Pure Urology viewers, good evening one and all. As you all know, we are discussing surgical technique based presentations every other day or alternate day in this Pure Facebook forum. Please invite your urology friends to join and make it a bigger group to listen such topics and share, learn the knowledge and progress towards better care towards the patients. Today we are discussing about the stone disease in an abnormally located kidney, that is ectopic kidney. As you all know, ectopic kidney means actually not 1 to 2 centimeters kidney lying in the loin. Truly ectopic kidney is something like pelvic kidney surrounded by bowel all around. Small bowel, large bowel, anything can come between the abdominal wall. Second point is where C-arm cannot be used easily. Third point is where ultrasound may be useful or lap may be useful or PCNL may be useful or RIRS as a matter of fact. So this is an interesting topic because of the ultrasound detection of these cases have increased. I have seen myself in my hospital as well as many other hospitals and peripheries, lot of cases are done because of the RIRS probably. So today our speaker is Dr. Manoj. Before I talk about Dr. Manoj, I wanted to re-announce about our next month 6th supine versus prone PCNL workshop we are doing. This workshop is a live workshop. We have pulled up around 10 cases to 15 cases. National faculty, Dr. Mansoon Agarwal, Dr. Sabnis sir, Dr. S.K. Pal sir, Dr. Janak Desai and some juniors. We have different PowerPoint presentations also on common topics. We have moderators also to discuss, and it is only one day program. Those who are registered will have pre-conference day gala dinner also. Please utilize this opportunity. We have already sent the brochures. If you have any doubt, you can contact Mr. Rajendra, whose name is already known. His number is also displayed at the end. Also, I will announce. With this, Mr. Rajendra number is 92463 39066. 92463 39066. With this, I will tell about Dr. Manoj. Dr. Manoj, actually, I also have interaction. Dr. Manoj was with us as colleague practitioner for 1 year. I know in detail about him, but let us listen from him where he developed this interest of RIRS, lap as well as transplant and other surgeries of urology. Dr. Manoj, hi, good evening.
Good evening, sir.
Yes. Dr. Manoj, you did your MBBS from which place?
Sir, my MBBS was from Guntur Medical College, sir.
Which year?
2003 batch, sir.
2003 batch. Probably I must congratulate that you are the youngest player in this pure group to present the talk, because recently I have seen your video in the state conference which bagged the first prize. I was impressed, so I thought let juniors know, and also it is an encouraging to juniors that no surgery is like previous days. It will not take 10 years, 20 years time. You can learn because of technology. He is an example where he is doing lap, he is doing PCNL, he is doing RIRS. So after MBBS, where did you do your MS?
I did my MBBS from NRI Medical College, sir. In
NRI Medical College.
Yes, sir.
And after that, MCH from?
MCH from King George Hospital, sir. The Andhra Medical College.
Who was your mentor in King George?
Sir, Subbareddy, sir.
Subbarao.
Subbarao, sir. Subbarao, sir.
Subbarao and any other consultants with whom you have worked?
Chandrasekhar, sir. Rambab, sir.
Yeah. In Vizag Medical College, do you have all the facilities when you are there? PCNL, everything was there?
Yes, sir. Yes, sir. URSL, PCNL, everything. Endo-urology
is
completely there.
And your unit
not there, sir.
RIRS was not.
Just before I'm leaving, just the scope, they were just bringing the scope, sir.
But it is also known unit for the transplant, na?
Yes, sir. Transplantation we do regularly, sir.
Regularly. Subbarao sir is very famous transplant surgeon in Andhra Medical College.
Yes, sir. Yes, sir.
So after that, you moved to us. I think in Preeti Hospital you joined, and then 1 year you worked nearly.
Yeah, nearly 1 year, 4 or 5 months I was there. Sir.
You did learn RIRS and lap, I think here, and then you moved to Kurnool.
Yes, sir. After that I moved to
Kurnool. Now Kurnool, which hospital you are working?
KIMS, sir. KIMS branch of Hyderabad.
How many years now after you left Preeti?
This April 3 years, sir.
April 3 years. Oh, great. Great. With this same introduction, probably I will do on officially. So, Dr. Manoj is MBBS, MS, MCH, young consultant who is very active and learned surgery very fast with us. And he is a urologist and andrologist at KIMS Kurnool. Area of interest endourology, RIRS, laparoscopy, reconstructive also. 1 year experience as assistant professor in NRI Medical College, senior residency in Usmania Medical College, and laparoscopy and RIRS also at Preeti and Urology and Kidney Center. Performed more than 1500 surgeries individually now. That is a good, we are proud of you being with us. And now over to you for the talk regarding the surgeries and individual case scenarios of ectopic kidney stone surgery. Thank you, Manoj. Over to you.
Thank you, sir.
You take time, no problem.
Yes, sir. I am sharing my screen, sir.
Yeah. Yes.
Yeah.
It's visible and you are audible.
Okay. Good evening, everyone. I should thank Dr. Chandramohan sir for giving me this opportunity to talk on ectopic kidney stone management in Pure Urology group. And I really thank him for encouraging young urologists and also showing us so many videos and showing us so many surgical techniques in his Facebook, in his YouTube, and showing so many techniques for us. And I'm here, I want to actually, I really see every video. I really try to see every video from you, sir. I watch every video which you keep in this group. And I also try to watch every program in Facebook Pure Urology group.
Yes.
Thank you for that, sir. So I'm starting the topic, and this is a stone management in ectopic kidneys. So before going to the main surgical techniques, I'm just going to briefly discuss about embryology, which will be useful for surgical technique. So any position other than renal fossa is called renal ectopia. So usually the kidneys will be positioned around sacral region at 5th week. And as there is a rapid progression of the cauda region, there is a migration of the kidney above. So by 8th week of the gestation, the kidneys will be positioned around at L2 region. So there are two main points we should keep in mind regarding this embryology. One is at the 5th week of gestation, the hilum of the kidney will be positioned anteriorly, and as it goes upwards, the hilum will be rotated medially to 90 degrees, and the hilum will be positioned just medial to the renal parenchyma at L2 region. So we have to keep in mind that in pelvic position, the anatomy will be different, and the calyces, which we cannot say that anterior posterior calyces, and the pelvis will be positioned anterior. In the same way, regarding to the blood supply, these kidneys in the sacral region, they get their blood supply from iliac vessels, and as they go above, they get their newer blood supply from the common iliac aorta, and the previous blood supply will be disappear, and again newer blood supply will be appearing. So after going to the L2 region, main renal arteries and renal veins will be appear, and so we have to keep in mind that when there is when the kidneys were in the pelvic region, there can be multiple vessels and there can be a different vascular anatomy, which we should be careful while doing procedures. So there are different types of ectopic kidneys. One is pelvic ectopic kidney. It can be in the ileum, it can be a thoracic region, and it can be a cross-fused ectopica. Coming to the brief introduction, ectopic kidneys, the incidence is usually 1 in 700, of which pelvic kidney is common. It is 1 in 2200 to 3000. Coming to the gender, males, there is no differentiate between male or female in case of ectopic kidneys. Usually left side is more common compared to the right side. We all know that formation of stones is more common in pelvic ectopic kidneys. The main reason is abnormal rotation and anatomy. high insertion of the ureter. These causes decreased drainage of the urine and stagnation of the urine, which results in the stone formation. And the presence of abnormal vasculature can also cause obstruction to the flow of the urine and causes the secondary stones formation. And some studies say there is a decreased uretropelvic mobility in the retroperitoneum because of the adhesions between the retroperitoneum and uretropelvic junction because of the fibrin deposition. So main challenges in performing surgery for ectopic kidney stones are, first thing is selection of procedure. So it is very difficult to opt for a single particular procedure, and there are so many factors we should consider before going to the procedure, like density, position, size, and the drainage of the kidney, like that. And also there are multiple bony structures. There are presence of bony structures in the pelvic region, and there is a chance of injury to the renal vasculature, and also presence of the abdominal structures covering the kidney. And even though you fragment the stones, the main thing is there is a chances of significant residual fragments because of the poor drainage. So there is a algorithm for these anomalous kidneys in British Journal of Urology. They decided the stress management based on the size, based on the density and the drainage of the system. So if the stone is less than 1.5 centimeters, if the density is less than 100, definitely you can opt for ESWL if the drainage is good. In all of this scenario, if the drainage is bad, this generally suggesting to go for PCNL, because any procedure, either ESWL, RIRS, can cause significant residual fragments if the drainage is less. In the same way, if the drainage is good, if the stone is more than 1.5 centimeters in size, if the drainage is good, you can go for RIRS. If the stone is even up to 2 centimeters, you can go ahead with the RIRS, but you have to stage the procedure and you have to explain to the patient. If the stone is more than 1.5 centimeters and higher density, drainage is bad, we have to check for the presence of extrarenal or intrarenal pelvis. If the pelvis is extrarenal, we can go ahead with laparoscopic pylorolithotomy. If the pelvis is intrarenal, we can go ahead with either ultrasound guided PCNL or laparoscopic assisted PCNL. And that you have to check before a surgery with ultrasound. If you can have some acoustic window between the skin and calyx, you can go ahead with ultrasound. If you cannot find an acoustic window between the skin and calyx, we have to go for either lap assisted PCNL or CT assisted PCNL. So coming to the procedures, ESWL
usually in normal kidney stones, this is the choice of method for stones less than 15 mm in normal kidneys, and in lower pole less than 10 mm. But here, because of the stone size is the main factor deciding for the stone free rate. Stones less than 1 centimeter, the success rate is 80 to 90%. But stones more than 1 centimeter, the success rate reduces to 60 to 70%. In the same way, stone density also, higher the density, less chance of fragmentation, less chance of drainage is there. And kidney position is also very important. In lumbar kidneys, drainage will be more. In pelvic kidneys, the drainage will be less. In some studies, the pelvic kidney drainage with ESWL is almost very less, like 10 to 20%. So it is better to avoid ESWL in pelvic kidneys and stones more than 1 centimeters. The factors that are reducing its efficacy are bony pelvis, which we cannot give shock waves from posteriorly, and also presence of bowel loops, which will interfere with the transmission and decreases its efficacy. In the same way, drainage of the kidney is also impaired in most of the cases. So the significant residual fragments will be there. And it needs multiple procedures to clear the stones. So RIRS is gaining popularity nowadays for small to medium sized stones. Even up to 20 mm stones, we can go ahead with RIRS. The success rate is 75 to 85%. The main challenges with RIRS are presence of tortuous ureter and high insertion of the ureter, and there is high chance of scope damage with RIRS in ectopic kidneys because of the
tortuous ureters and high torque of the scope. So it is you have to be very careful to prevent the damage of the scope. So I am presenting two cases of RIRS which were done by me. This is a male patient, 21-year-old. He came to me with left iliac fossa pain. On CT scan, it was suggestive of left two stones in the left pelvic kidney. One is 18 mm, another one is 4 mm. So I have decided for RIRS, which is a less invasive. So I have done DJ stunting 15 days prior, and after 15 days, I have decided for RIRS. I removed the DJ stunt. So you can see the angulation of the ureter. I have kept a safety guide wire, and I passed a stiff guide wire. Over the stiff guide wire, I passed access sheet. So usually I don't pass flexible scope over the guide wire, but as there are multiple kinks and tortuosity, I had to pass the flexible scope over the guide wire. This is the smaller stone which was present in the upper calyx, which is a straight, which is in straight position. I could able to fragment it easily, but to reach the larger stone, it was very difficult for me. I had to do a lot of medial rotation of my shoulder. You can see the rotation, and with a lot of difficulty, I could able to see the stone. Luckily, the outer part of the stone is a little bit easily fragmentable. I started fragmenting. I used a dusting technique to fragment the stones. So even though I was fragmenting, I was a little worried because whether I could able to complete the stone or not. But after a certain point of time, I could able to see the most lateral part of the stone. Then I was very confident, and I proceeded with the surgery. So I started. I did a dusting technique. Inner part of the stone is a little hard in consistency. During the whole procedure, the scope was in a lot of strain, and this strain this may cause the scope to get damaged. So after 40 minutes, I could able to fragment the stones to a smaller parts. After the stones were fragmented to smaller one, I did a popcorn technique.
Don't fast forward. No need to do fast forward.
Did a fragmentation, popcorn technique. So that is the powder formed after dusting. So I slowly by removing the scope from the calyx, I could able to remove the fragments from the lateral calyx. So after 40 minutes, it was completely cleared. So I kept a DJ stunting, and post-operatively there is in the first post-operative there is a little bit of pain is there, and it was controlled by analgesic, and he was discharged on the second post-operative day. Ultrasound was done. There are no residual fragments. So one more case. She is a young female. Left pelvic ectopic kidney, left ectopic kidney. So she was stunted outside. She came to me for stone removal. So as she was already stunted, I opted for RIRS. Before doing RIRS, I did RGP. There is a small kink in the upper ureter, but I could able to negotiate it. And I like previous case, I passed the scope over the guideway, and this is a little bit easier case compared to the previous one. The stone is in front of the scope. is also easily fragmentable. I used the dusting technique. So approximately it took 20 minutes to completely clear the stone. This is the these are the powder. This is after the stone removal. So I kept a DJ stenting. This is an uneventful case. Post-operative on the day one only, she was discharged. So before going to the main things are, before going to the procedure, you have to do RGP, so that you can assess whether you can reach the stone or not, and so that you can abandon the procedure without much delay. And for the patient, you have to explain about the failure of the procedure, and also you have to explain about the conversion to other procedures before going to the RIRS. So next treatment of choice is PCNL. So main challenges for PCNL are bony pelvis, abnormal pelvic calcium anatomy, unpredictable blood supply, and the presence of loops of intestine covering the kidney. So there are mainly two types of PCNL over there: ultrasound guided PCNL, laparoscopic assisted PCNL. So there are so many studies over the ultrasound guided PCNL over there, and they were all showing that ultrasound guided PCNL is safe and effective if you select the case properly and you follow some proper safety techniques. So while doing ultrasound guided PCNL, patient will be in supine position. You have to put a sandbag or roll over the sacrum onto the side of hemipelvis, which side you are doing, so that it will push the sacrum above, and also it pushes the kidney above nearer to the anterior abdominal wall. And also you can press the ultrasound probe over the abdomen towards the kidney, so that the bowel can be displaced away from the kidney. And you should use color Doppler so that you can avoid major blood vessels during the ultrasound. And you can do dilatation under fluoroscopic guidance after puncturing the kidney. So this is one more case done by me. She is a 60-year-old female patient. Came to me with left iliac fossa pain on IVP and CT scan. We found out there are 2 stones in the left pelvic ectopic kidneys. She insisted for RIRS, so I explained about the multiple procedures and I did DJ stenting prior. So after 15 days of DJ stenting, I removed the DJ stent and I planned for RIRS. So this is the access sheet kept under CM guidance over the guideway. Through the access sheet, RIRS scope was passed. You can see the angulation of the RIRS scope and in the ureter. This is the endoscopic view. So once I enter into the kidney, I could able to see only a small part of the stone. I tried to push it, but there is no space for the stone to move. And also I tried to fragment it. I could able to fragment a small part, but I could feel that my scope is at a lot of strain. So I stopped the RIRS, decided to go for ultrasound guided PCNL. We could able to see an acoustic shadow where there is no bowel between the abdominal wall and the kidney. So after doing puncture, contrast was inserted and the dilatation was done under fluoro guidance. So after entering into the kidney, it is like any other PCNL. You can fragment the stone and you can remove the stone without any problem. So you have to be very careful while doing puncture in ultrasound guided. Main things are you have to see whether there is any bowel between the abdominal and kidney, and also you have to check for the color Doppler to prevent any major vascular injury. So she had a post-operative fever on first day, and fever was controlled with antibiotics, and she was discharged on the 4th post-operative day after nephrostomy removal. So next case is a young female. You can see this young female who came with the upper left iliac left pelvic kidney with upper ureteric stone with gross dilatation of the kidney. So she is a thin female. On examination, I could able to feel the stone. So you can see there is no, even in CT scan also, you can see there is nothing between the abdominal wall and the kidney. So after seeing this CT scan, I have decided that even though the stone is smaller, I have decided to go for ultrasound guided PCNL in this case. And
Do you routinely use ultrasound in PCNL?
No, sir.
Occasionally you use.
Usually for PCNL, I don't use ultrasound, sir.
In this case,
This case to prevent any, to see for any bowel, I use ultrasound.
What ultrasound do you have in your hospital? Philips or any?
Philips, sir. Philips.
Philips. So routine ultrasound, not BK.
No, sir. Routine ultrasound.
So one must be well versed with ultrasound, at least minimum basics.
Yes, sir. Usually I use ultrasound for lower obstructions like CA cervix and all. I use ultrasound, sir.
Okay.
For
normally in all government institutions also, students will get opportunity to use the ultrasound in obstructed ureters.
Yes, sir. Lower for CA cervix and all.
CA cervix. There only we learn. Yes, the same principles we will use here, and also we should know how to see the bowel also.
Yes, sir. Here also I use a lot of ultrasound for PCNs.
PCN.
For PCNs, I'm using ultrasound. With that experience, I could able to come.
Okay, good.
So this is the case, and this is a little bit easier compared to the previous case. I could able to do the puncture in the second attempt, and this is after fluoro. So the dilatation was done under fluoro guidance.
And here only thing is how confident. Keep playing. How confident that bowel is not coming? Almost skin and kidney will be nearer when you are puncturing.
So after puncturing, I can target the kidney.
Yeah. So you are 100% sure that there is no surface between the skin and the kidney.
Yeah, previous case I was a little bit worried, but this case I am very confident that.
Confident.
You can do lap assisted PCNL for this one, but laparoscopy will be
Hello?
Hello?
Yes. Voice is little breaking. No problem.
So the stone was identified. This is upper ureteric stone, almost 13 to 14 mm, and it will be easily broken. This is the post-operative scar, and she was discharged on the third post-operative without any problem. So those are the cases done by me. So other types of modalities for ectopic kidney stones are laparoscopic guided PCNL, laparoscopic assisted PCNL. For stones, for larger stones more than 2 centimeters involving the pelvis, and also there are stones involving the calyces, this is the gold standard of treatment. It can be done either transmesocolic or after colon mobilization. We can do either calyceal puncture, pelvic puncture, or RIRS assisted. So I'm showing a video of laparoscopic assisted PCNL. This was taken from internet. Main important things while doing RIRS lap assisted PCNL is you have to identify the position of the stone, position of the kidney. So this can be done by either X-ray guided or CM guided, or you can do either RIRS assisted identification of the stone, identification of the kidney. You have to be very careful while mobilizing the mesocolon and to prevent the injury to the kidney, injury to the vessels in the mesocolon. You can puncture either the pelvis or the calyx. Either can be done. Even the pelvic punctures, pelvic puncture and pelvic dilatation is considered safe, and it is safe in many studies. So main important thing while dilatation is there is a chance of slippage of the guide wire from the kidney while doing the dilatation. To prevent that, intra-abdominal pressure should be reduced from approximately 14 to at least almost 8 to 7 mm Hg, so that the dilators won't slip out from the kidney. And also you can ask your assistant to press the abdominal wall towards the kidney so that the dilators won't come out of the kidney. You can dilate the kidney to whatever required size you want, and after dilatation, it is like any other PCNL. So definitely this is much safer compared to the ultrasound guided PCNL. You can avoid injury to the bowel and you can avoid injury to the any vasculature. And after doing PCNL, you have to keep a nephrostomy tube. You can avoid a stunt if you can avoid stunt, and PCN can be removed after second postoperative day. Next method of choice is laparoscopic pylorolithotomy. Main indications for presence of pelvic stones without any calcium stone, anteriorly placed pelvis or laterally placed pelvis. It can be done either retroperitoneal, transperitoneal or transmesocolon. So this video was taken from internet. So usually the position can be supine or with the leg split. It should be in Trendelenburg position on the kidney side, raised to 30 degrees. You have to open the posterior peritoneum. You have to identify the pelvis carefully. Usually this is done in anteriorly placed pelvis. After opening the pelvis, stone can be easily removed. You can either keep ureteric catheter or you can keep a stent. The defect and the opening is closed with 40 Vicryl. You can keep it abdominal drain. And if all the surgeries fail, there is definitely you can do open surgery. So coming to the conclusion, selection of case is very important while doing the procedure, and the selection depends upon the position of the kidney, position of the stone in the pelvis or calyces, and size of the stone, density of the stone, and the drainage of the kidney. And in this case, I want to tell you that ultrasound guided PCNL is safe and effective if you select proper case and you do take some precautions while doing the procedure. Thank you.
Okay, thank you, Manoj. We'll have a quick questions. Normally in ectopic kidney, some amount of the PUJ narrowing may be there because of two reasons. One is a cup kidney where lower part of the parenchyma may raise the pelvis. Second thing is the primary congenital PUJ may be more, because of which stone might have formed. So because in the era of the CT we are missing IVP.
Yes, sir.
So on table, when you do RIRS, you usually stent it.
Yes.
So when you go with flexible scope, you may go easily, and postoperatively patient may get fever. And do you think RGP just before starting or stenting may be useful, or depending on extrarenal dilatation and ultrasound seen by the urologist, you wanted to get doubtful cases DTPA? This is my doubt, because whenever you choose RIRS, if there is mild PUJ, too much powder also sometimes may not come out.
Yes, sir.
I hope you got the point.
Yes.
So, what is your experience? You wanted to comment on that?
If you have any doubt, like if there is a chances of defective drainage or delayed drainage in either CT scan or anything, better you go for any study that shows drainage, either IVP or DTPA. I do
IVP or DTP?
For my cases, I did IVP, sir, for 3 cases. So it is okay. IVP and to see the anatomy and also to see for the drainage.
I think for documentation and better orientation, IVP is not a bad idea in ectopic kidney,
Yes,
because CT will not give that much view as the IVP gives. That is correct. So better take chance on the contrast and do IVP, not harmful. Once upon a time, IVP is gold standard. At least in some cases, we must use that. That is fairly acceptable. Second question: have you changed anything what you have learnt with us in Preeti Hospital some time back in your fragmentation or in your powder? Do you still feel that proper dusting is better in RIRS, or in a small stone you better to take out 2-3 pieces? What is your feeling?
After coming here, sir, after coming out from no, sir. Dusting is better only. In the last parts, I think fragmentation is also okay, sir. Last part you have to fragment little.
So you feel that in RIRS to have good results, better to do dusting from beginning to end, better.
Beginning to end is better. In later part, in the later part, if sometimes you may not able to dust the stones. Able to fragment it to the required size. Then you have to remove the stones. I did some basketing. If I cannot able to reduce the size of the stones to the required amount.
Yes. So, have you seen any case totally mal-rotated, normal positioned kidney, little bit anterior location, or horseshoe kidney? Have you done any RIRS?
No, sir. No, sir. I didn't get any horseshoe kidney.
There is no difference, I feel, because in RIRS, entry point is urethra and exit point is calyx. If you can reach the stone, whether it is in the thorax, whether it is anterior rotated, whether it is in the ectopic, whether it is in the opposite side, should not make difference as long as you reach the stone. That is one.
I have seen your videos, sir, where there are stones in isthmus and all.
So if it is not coming in flexi, I think you already mentioned that there will be some awkward angle in ectopic kidneys with flexible scope. Do you think that scope damage may occur if you are not experienced?
Definitely, sir.
Definitely, because torque will be there, flexion will be there. Using laser, you need good assistance. Everything is important.
You can see my first scope, sir. In the initial, there are no dots. In the fourth case, you can see a lot of dots.
Fourth case, around 7-8 dots. I have seen that. That is true. So dots means you are losing the scope and you are losing the money also. So one should be careful in attempting large stones. What do you think you can manage if easy case? That means easy in the sense ureter dilated, pelvis easy. Up to what size you will venture now in ectopic kidney straightforward pelvic stone? 2, 2.5, 1.5. What do you think? 2. So I also feel 1.5 to 2 is good choice. 1.5 initially, 2 with experience. Anything more than 2, slightly have less, go for PCNL is better.
You can completely clear with the post-tented or dilated, good dilated.
Yes, we can do it. Do you think that in these cases, have you ever felt that access sheath short length should be used because they are in the pelvis? Usually what size you use, 28 or 35 or 45?
28, sir.
28. We all use 28, we are comfortable. Water will anyway come down from the ureter and you can do, because if you use longer, too much will be outside.
Yes, sir. Longer, too much will be outside.
I also have a question. Crossing PUJ with access sheath in this case is very dangerous. What do you think?
Yes, sir, definitely.
They are hanging ureters.
We remove a little bit back, sir, because of the
better to be below than any heroic measure, because your ureter and pelvis may get damaged.
They were angulated, sir.
They are angulated. Even post-tented also, they won't straighten as much. So better not to use the access sheath into the pelvis or nearer to the ureter. Avulsion may occur also. Have you, how many cases of RIRS after fragmentation, apart from relocation, you are using basket? As generally we don't use basket, you know that. Are you using basket other than relocation?
I did basketing for a few cases only, sir.
Yeah.
Like I said before, certain stones I am unable to do fragmentation to the required smaller size. So
you want to remove them. You want to remove them.
And pediatric cases, I did basketing to further stone fragment.
For the stone, this thing.
Stone
So,
analysis.
which basket you are using routinely? Encircle?
Retinal basketing, this one.
Retinal encircle cooker.
Encircle basket.
So there is a basket you may be knowing, Dakota 1.9.
Yes,
Nowadays Dr. Ramakrishna is using commonly and it is very good. And even Oliver Traxler's favorite basket because it can release the stone if you are Dakota. It is like a tri-prong without sharpness.
I have seen that, sir.
It is good. You can try. It is 1.9. Only problem is passing and removing through the scope. You need patience because it is very thin when compared to 2.2 French.
Okay.
Even though it is 3 French difference, wide opening of the channel, I mean cap will be there. Now it won't fit easily. It is flexible too much, like a guide wire.
Okay.
In ectopic kidney, when you are doing RIRS, do you think 2 guide wires in position may be better or not that much necessary?
Needed, sir. I think for these 2 cases, I passed flexible scope over guide wire.
No. Outside sheath, you do keep any guide wire? Not necessary.
I always keep guide wire outside.
So it is a very important point. I am feeling very happy that your answer is correct. Please.
Even for large ureters, even for very dilated ureters, I keep guide wire.
Very good. For all the audience, juniors who wanted to do it, keep a small guide wire outside because at the end of the procedure also if you want to pass stent, suddenly if edema comes, if there is no access, you will be really scared if you don't pass stent after the procedure. So these are the ABCD of RIRS that up to you reach a level of confidence like 100 cases, don't skip the guide wire outside access sheath. And as he mentioned, pass a guide wire inside and then pass the access because these are curvy and ureters. Why to unnecessarily damage the scope?
But guide wire also acts as a, when we are passing the flexible scope, it will give some strength. While
it will give strength and scope will not get damaged. Yeah. And at the end, you remove the guide wire and aram-se you do this thing. I have seen one problem with ectopic kidney. Inferior and posterior lateral calyx, if any fragments going into that is difficult, whereas superior calyx and pelvis are easy. So if you miss any stone while that's why you should not fragment. What you said is correct. So in pelvis, if you make fragment, they may disperse and you may not be able to go to all calyces. Do you agree that?
Definitely, sir.
Acute angulation will be there. Pelvis is small and one calyx will be one direction.
Yes, sir.
They won't be uniformly directed. They are very difficult and scope will be have extreme torque. So these are the points we have to remember. And what scope you are using?
XX2S, sir.
XX2S. It is more flexible than P7. Even though vision is slightly inferior. From beginning you are using the same scope?
Same scope, sir.
Same scope. Durability, how many cases it is coming average for you?
From beginning I am using the same scope, sir.
Average, in your experience, 50, 100 cases it is coming?
Yes, sir. It is more than 150.
More than 100 cases it is coming. Yeah. How many of your cases are pre-stented now? Apart from the ectopic kidney generally?
10%. Sir.
10 to 50. First you will try with a normal ureteroscope and then try. Like standard fashion. So, among all these cases you have done, which one you feel that difficult, last question it is, difficult case for RIRS and better to go for PCNL? When do you feel after entering, for example, you attempted, I had 2 big stones and 1 small stone. I have done small stone RIRS. After that I realized that 2 stones are not at all possible with RIRS. So when will you feel that after going inside, you don't want to do RIRS? And will you tell the patient 2 options before surgery or not?
Yes, sir. I will tell 2 options, sir, initially. Main thing, even I can convert it to PCNL, but my main worry is sepsis, sir.
Sepsis, yes.
Main worry is sepsis. When I go inside and I don't see any fluid coming out of the access sheath, then I will be little worried.
That's all.
When there is an upper ureteric narrowing and my scope passes with kinks and all, especially in older people, I see like this, sir.
Yes.
Upper uterus will be a lot of kinks will be there. So they would enter, but fluid won't be coming outside.
Yeah, then you should That is also our favorite point. So that is a very correct answer. Rather than size, these are more important. You can do a little bit error on the size, but not error on the outflow, tight ureters, kinky ureters. Better to avoid. So I am really happy that you are doing well. RIRS lab also pyeloplasty. I have seen some of the videos. Keep doing the same. Educate the juniors and keep growing. Thank you, Manoj, for giving the talk. Very nice talk.
Thank you for the opportunity.
Thank you. So this talk also got the prize in our state conference. So I must congratulate for that. Thank you very much.